All right. Why don't we go ahead and get started? Because I do want to be sure that we have enough time to listen to you and ask questions. So welcome everyone to another week of virtual cardiovascular grand rounds. This is definitely one of those weeks that I very much wish that we could have done this in person and had you here in New Haven. But it's an absolute pleasure today to have with us virtually Dr. Don Lloyd-Jones, who is the current president as of last week, a couple weeks ago, of the American Heart Association for 2021-2022. He's also the chair of the Department of Preventive Medicine and the Eileen Foyle Professor of Heart Research and Professor of Preventive Medicine and Pediatrics at Northwestern University. He attended Swarthmore College as an undergraduate, Columbia University for medical school, and the Harvard School of Public Health for his master's in epidemiology. He was a chief resident, and cardiology fellow at MGH. Initially was junior faculty at Harvard Medical School before he moved to Northwestern in 2004 and has been in Chicago ever since. A main focus of Dr. Lloyd-Jones' research is on the life course and mechanisms of chronic diseases of aging, focus on lifetime risks for various cardiovascular diseases and the factors that modify those risks. Other areas of interest include cardiovascular risk estimation using novel biomarkers, as well as epidemiology of common cardiovascular risk factors. He really has been, I think, one of the leading voices in cardiovascular prevention and interests that we share. He was instrumental in the first ever definition of ideal cardiovascular health and the criteria for AHA's Life Simple 7, which is something that we're all very familiar with and use often. He co-chaired the expert working group that created the 2013 ACC-AHA guidelines on the assessment of cardiovascular risk and has authored more than 350 peer-reviewed publications. It's a real honor. And like I said, this is one of those times I really wish that we were, all sitting together and hearing your talk, but irregardless, it's a real honor to have you here today. And he will speak to us on cardiovascular health across the life course, outcomes, determinants, and mechanisms. Thank you very much, Dr. Don Lloyd-Jones.
Thank you so much, Dr. Numa. Really kind and wonderful introduction. And I so wish I could be there in person with you as well. So we'll look forward to that in the future. And let me thank Dr. Velasquez as well for the invitation to speak and share kind of what's been my passion for the last decade, which is since we were able to define a formal kind of construct of cardiovascular health, our group here at Northwestern and many others across the country have actually kind of dug in on this concept and tried to figure out, well, what does it really mean? Not thinking about risk or disease, but actually thinking about health. So I want to share with you a little bit about that journey that we've kind of undertaken over the last decade and explore some, as Dr. Numa said, explore some of the outcomes, determinants, and mechanisms of cardiovascular health as it plays out across the life course. So I have no disclosures. So obviously, we know that the major cardiovascular risk factors, have been known and well described since the 1960s and 1970s, starting with Framingham and following on with a number of other cohort studies. But our group, led by Dr. Jeremiah Stamler, who just had his 102nd birthday, so that's good prevention right there, really kind of started to think about the obverse, which is to say, okay, we've defined risk, but can we think about healthy people and study healthy people and how they actually undertake healthy aging to understand a little bit more about this process of health and how we can preserve it for as long as possible? And a major step forward really came in 2010, as Dr. Numa pointed out, with the formal definition of cardiovascular health by the AHA, also sometimes referred to as Life Simple 7, in this document. And I was really fortunate to be able to chair a group of, as usual with the AHA, incredibly stellar volunteers who were deep thinkers about what we could do with this, the prospect of this construct. And it all came actually from the board, the national board of the AHA, kind of challenging the organization to say, okay, we've been focusing on cardiovascular disease, we've been focusing on cardiovascular risk. Let's pivot and add a new focus on cardiovascular health promotion as well. And so they charged our committee with kind of defining cardiovascular health and then filling in the blanks of this statement. So we were working in 2008 and 2009 to first define cardiovascular health and then fill in the blanks. And that would be then the goal for AHA for the decade of 2010 to 2020. So to undertake this process, we actually, as we all would do, went to the literature and said, okay, is there something out there that would point us to a construct that looks like health? And Dr. Stamler, as long ago as 1999, had started to flip the risk paradigm on its head and to think about health using some large data sets that he had access to, and really focused in on these lower risk people who had very low cholesterol, optimal blood pressure levels, weren't smoking, didn't have a history of diabetes, and no history of pre-existing cardiovascular disease as well from some of his cohort studies. And what he found was that those individuals, even at pretty young ages, had dramatically lower cardiovascular disease mortality rates over the ensuing decades, much lower all-cause mortality rates as well, and therefore, obviously, much greater life expectancy. So that for us looked like a starting point. This sort of package of optimal risk factor levels suggested that this might be a really good place to start in defining a construct of cardiovascular health. And when I was at Framingham, we started this work and finished it when I was here at Northwestern, but we were able to look at people in Framingham who obviously had been followed for decades. And we actually kind of described them as they passed through their 50th birthday under observation in Framingham. And in these data, what we showed was that if you were a man or a woman who had 2 or more major risk factors already present on your 50th birthday, you can see your remaining lifetime risk for developing cardiovascular disease was quite high, somewhere in the 50 to 70% range. And even those people who had just one risk factor at not quite optimal levels, as we would define them clinically, had pretty high lifetime risks in the range of 30+% for having cardiovascular disease before they died. But the really interesting group was this relatively uncommon group down at the bottom in the blue line who had negligible risks for cardiovascular disease over their remaining lifespan if they made it to their 50th birthday with all optimal risk factor levels. So again, kind of building on what Dr. Stamler had shown a few years earlier to say that maintaining this package of optimal risk factors looks like a really good way to not only live longer, but live longer free of cardiovascular disease over the course of your lifespan. And then Dr. Mayer Stampfer, a different person at Harvard, actually kind of expanded on this concept by looking not just at risk factor levels, but at health behaviors and some of the health behaviors that could contribute potentially to prolonging life and prolonging health through life as well. And so these are data from the Nurses' Health Study, where he looked at 5 healthy lifestyle factors. You see them here: non-smoking, participating in physical activity, maintaining a lean body mass, higher dietary scores in something that looks like a DASH diet. And then here's the good news, by the way, drinking half a glass of wine per day or its equivalent in that range, again, in these mostly middle-aged nurses. And what Dr. Stamfer's team found was that women who followed 3 healthy behaviors compared to women who followed fewer than 3 had a 57% lower risk for coronary heart disease over the next 15 years or so. Women who followed 4 healthy behaviors, 66% lower risk. And women who followed all 5 of those healthy behaviors had an 83% lower risk for coronary heart disease, in the intermediate term. So that looked to us like another kind of feature here, that if you could kind of bundle these healthy lifestyles with those healthy risk factors, it might be kind of the secret sauce or almost the fountain of youth for prolonging life and prolonging health. So in putting together the definition of cardiovascular health, we wanted to satisfy a couple of things. One, understanding that health is a more broad and positive construct than just being absent disease, right? So cardiovascular health is more than just the absence of cardiovascular disease. We looked at our evidence base. There was a lot more to look at as well. We wanted this to be simple and accessible, something people could actually take action on. And for AHA's purposes, of course, it had to be measurable, monitorable, and modifiable so that we could actually improve and promote the cardiovascular health of the population. So when all was said and done, we chose these 7 factors: some health behaviors, some health factors. We defined an ideal construct where all 7 were at optimal levels based on sort of clinical cut points. And that became our definition of ideal cardiovascular health. But we understood that there's obviously a huge spectrum of health across the population. And so we defined each of these 7 at poor, intermediate, or ideal levels, as you see here. I'm not going to go through those in detail, but they should make sense to you. And obviously the goal was to move people from poor to intermediate or intermediate to ideal in order to help them promote their cardiovascular health. Now, for the rest of the talk, as I think about cardiovascular health and present it to you, there's often a summary that we do, and we turn this into a score, either just simply counting the number of those 7 metrics that are at ideal levels. So that would be an ideal CVH score that would range from 0 to 7, or thinking about the total cardiovascular health score, which could range from 0 to 14 when we assign 0 points for a poor metric, 1 point for an intermediate metric, 2 points for an ideal metric. Then you can see how it could range from 0 to 14. And this was really designed to monitor the cardiovascular health of individuals or populations over time. Wasn't really designed to be a risk score, but as you'll see, it doesn't work so badly, as it turns out, as a risk score, among other uses that have actually come into play over the ensuing decades since this was published. Okay, so at the end of that process, we proposed, and the AHA accepted this challenge, that from the decade of 2010 to 2020, the goal would be to improve the cardiovascular health of all Americans by 20%, while continuing to try to reduce deaths from cardiovascular disease and stroke by 20%. So this sort of 20% by 2020 goal came into being. And in that decade, as I mentioned, our group and many, many others have dug in and really defined this cardiovascular health construct across the life course, which is what I'm going to spend the rest of the talk showing you. But these are some of the outcomes that have been associated with cardiovascular health status. So not surprisingly, as I've shown you, total mortality and cardiovascular disease outcomes, fatal or non-fatal, strongly linked to your cardiovascular health status. But interestingly, things like cancer, things like cognitive function and dementia, things like compression of morbidity, which I'll talk about in more detail, and even pretty substantially healthcare costs in older life related to what your cardiovascular health status is more upstream in midlife and even young life. So we're going to kind of wander through some of these data through the rest of the talk as we think about, how cardiovascular health is really acting kind of like a fountain of youth, as I mentioned, prolonging not just your lifespan, but also your health span, the number of years you live without significant comorbidities. So let's focus first on those outcomes of cardiovascular health. I'm going to walk you backwards through the life course because this is kind of how we unfolded or unraveled the concept. We first looked at cardiovascular health status in middle age, where we had the most data initially, and we understood, how that might turn into ultimately clinical cardiovascular events or death, how it might be related through the process of development of subclinical cardiovascular disease. We'll look a little bit at that. And then as time went on, we actually said, okay, what determines cardiovascular health in middle age? Well, could it be young adult behaviors and lifestyles? So we looked into that, and we're going to talk about that a little bit later in the talk. And ultimately focusing in on very, very early processes, genetics, of course, but early life exposures, even fetal exposures in utero, and how those might program us for different trajectories of cardiovascular health across the life course. So that's a sort of a roadmap of where we're going to go for the rest of the talk. And I'm going to start right here in these initial studies where we looked at cardiovascular health in middle age and what kind of played out during the remainder of the lifespan. So these are data from the MESA cohort. As you know, those are middle-aged and a lot of older folks from one of our fellows at the time, Tammy Polonsky. And she showed a very direct log linear relationship between your baseline cardiovascular health score, ranging from 0 to 14, as you see here, and this, again, log linear relationship between that baseline cardiovascular health score, low cardiovascular health score at high risk, high cardiovascular health score at substantially lower risk. And you can see a pretty substantial and nicely direct log linear function there as well. In addition, in the ERIC study, the Atherosclerosis Risk and Community Study, you can see, again, using this ideal CVH score ranging from 0 to 7, this was actually the first outcome study done in middle-aged individuals, median age of 55. And what Aaron Folsom showed was that just having one ideal cardiovascular health metric compared to 0, there was a 36% lower risk of cardiovascular events over the next 20 years in this ERIC cohort. And then you see this nice sort of dose response effect from going from 1 to 2 to 3 and so on, all the way up to 7. And interestingly, among the relatively rare group of individuals who had all 7 metrics at ideal levels, 0 cardiovascular events in the next 20 years. This is several hundred individuals with 0 cardiovascular events over 20 years, going from age 55 to age 75. Pretty remarkable statement that, you know, there's a group of people out there who could do that. But I think, again, tells you about the power of maintaining the whole package, if at all possible, at ideal levels. And they took this even one step further and showed that whether it was the number of health factors, that is the risk factors at optimal levels, or the health behaviors, there was really a stepwise relationship. So if you had 0 health factors or 0 health behaviors at ideal risk, at ideal levels, of course, that was the highest risk. But then there was a nice sort of steady step down as you added either 1 health behavior at more optimal levels or 1 health factor at more optimal levels. And so it suggested that it didn't really matter what you focused on, that just improving your cardiovascular health and one of those things would actually lead to an improvement in risk. And that kind of makes sense, of course, but it was nice to demonstrate it in this way. And then more recent data from ERIC actually have asked the question, does change matter? And what we found here in this study from Bambagaye, who's actually in France, but used the ERIC data, is that baseline cardiovascular health score is probably the most important thing, but change does matter. So as you can see, sorry, didn't do that, there we go. As you can see here, people who over about 5 years went from poor to intermediate or ideal health had about a 30% lower risk for cardiovascular events in the top panel. Going from intermediate to poor still benefited because you started at intermediate, even if you got a little bit worse. But staying at intermediate did even better. Going from intermediate to ideal, better still. Even if you started with ideal but got a little bit worse, you still did really well. But the best, of course, was being in ideal health at baseline and then maintaining ideal cardiovascular health overall. And those people had roughly a 75% lower risk for cardiovascular disease compared to people who had always poor cardiovascular health. So again, you see this dose response effect. You see that change can matter and improve your risk, but having baseline cardiovascular health is even better than improving it later on. And so now moving upstream in the life course, now instead of thinking about older or middle-aged adults, now we're looking at actually quite young adults. This is the Cardia study. These individuals were 18 to 30 years old at baseline when their cardiovascular health status could be calculated. And what you see here is that for individuals with high cardiovascular health, that's a score of 12 to 14, as we defined it in this paper. You can see in the blue, very, very low event rates for those individuals, whether they were younger or older at baseline, men or women, Black or white participants, and regardless of education status, having high cardiovascular health in very early adulthood was associated with much lower rates of premature cardiovascular events during 30 years of follow-up. And of course, the converse, if you had low cardiovascular health in young adulthood, much higher rates of premature cardiovascular events up until about age 55 was the follow-up in this study. And Dr. Parak, one of my mentees, actually went on to show that, in fact, if you calculate the population attributable fraction, that is, if we could take everybody at lower intermediate cardiovascular health and magically snap our fingers, turn them into people with ideal cardiovascular health, her data suggests that we would have prevented 60 to 70% of those premature cardiovascular events. So, clearly, these modifiable risk factors that we measure routinely in clinic matter even, in your cardiovascular health status, even in very young adulthood. From ages 18 to 30. And then data from just earlier this year, we partnered with a group in Korea who has a wonderful data set of insured Korean young adults, where they've also documented the clinical factors and everything but diet in the cardiovascular health score. So you can see here, 20 to 39-year-olds, 3.5 million Korean young adults, got a baseline cardiovascular health assessment, 16 years of follow-up, and then a large number of them, 2.9 million, actually had a follow-up assessment about 2 to 5 years later after their initial assessment. So you could, again, look at change of cardiovascular health through young adulthood and see if that actually made a difference in their outcomes for premature events. And not surprisingly, so here you see the distribution of that baseline ideal cardiovascular health score, here ranging from 0 to 6. Not surprisingly, again, a dose response. People with 0 cardiovascular health score had the highest risk. People with 6 factors at ideal levels had very, very low risk. And again, that same dose response effect that we saw in the ERIC study in older individuals. And then to zoom in on this really nice graph here at the bottom right, what you see is that, again, your baseline cardiovascular health score matters most, but change also helps. So for example, if you started at 0 or 1 on your cardiovascular health score, and at follow-up, it was between 4 to 6, 66% lower risk for cardiovascular events compared to people who stayed with low cardiovascular health scores. But of course, if you started with a really high score down here in this corner and got worse, you still were at lower risk as well. But always best to be high cardiovascular health at the start and maintain that overall. So I think, what we see here is that the earlier you have ideal cardiovascular health, the better your outcomes will be. Change will always help you reduce your risk, but the earlier you change, the better, because the outcomes will be that much better. And then moving even a little bit further upstream, now we're not going to be able to look at outcomes because these are actually kids. We've created a synthetic cohort of a number of different cohorts from across the globe to be able to look at the trajectories of cardiovascular health in this study from ages 8 to 55. And what you can see here is that even by age 8, there's some stratification in the cardiovascular health score. In this case, it's a score that ranges from 0 to 8. But notice there are some kids who are at quite high cardiovascular health, but they have different trajectories thereafter. So some of them are able to maintain a pretty high cardiovascular health. Some of them have an early decline, and some of them have a somewhat intermediate decline. But notice these two groups here, there's kind of an intermediate cardiovascular health group that stays relatively stable with a late decline. And then already by age 8, a group of children who represent about 15% of the population who have already declared themselves to be in a low cardiovascular health state, and it only gets worse across adolescence and young adulthood. And in fact, what we showed was that these trajectory groups were actually associated with carotid IMT measured roughly in the 30s or so. So pretty significant differences in carotid IMT measurement in middle adulthood associated with these cardiovascular health trajectories that had been established really by age 8. So I think that's really striking that the further upstream we go in the life course, it still matters what your cardiovascular health score is in terms of your intermediate outcomes in this case. So I promised to talk about cardiovascular health and the compression of morbidity concept. And I think this is a really wonderful paper that Nori Allen here did to look at that using one of our Chicago cohorts. And what she did was she characterized people in middle age, it's about 40,000 individuals, characterized their cardiovascular health status in middle age. So roughly a mean age of 41. And then she was able to follow them for many decades, including using their Medicare-linked outcomes. So any Medicare claim that occurred for them or their death, we would actually be able to monitor it for decades, and in fact, up to about 45 years follow-up in this particular cohort. So starting in middle age, roughly age 41, and then following for up to 45 years. And what she found was that, if in middle age you had 2 or more major risk factors, that is high risk factors in this case. So high refers to risk factors, not cardiovascular health. What you see here is that she showed that the lifespan was shorter for those individuals compared to those who had all favorable risk factors or good cardiovascular health. And what you see then is breaking down that lifespan is here's what we call the health span. So the green part of the bar is the number of years lived during Medicare that people did not have any cardiovascular comorbidities. So for that group who had 2 or more major risk factors back at age 41, their average health span was 76 years. Their average lifespan was 84 years. So that meant that they spent about 8 years of their Medicare lifespan, or 43% of their Medicare lifespan, with some cardiovascular comorbidity on average. Now, looking at this group, the health span for those people who back at age 41 had high cardiovascular health notice their health span is substantially longer, 7 years longer. Their lifespan is about 4 years longer, and they spend much less absolute and relative time with cardiovascular comorbidities. So this is what's called compression of morbidity. You have to die someday, but you want to get sick as close as possible to your date of death, and that's called compressing the morbidity towards the end of life. And so this shows that cardiovascular health status in middle age really helps determine what your compression of morbidity, your health span, and your lifespan will be much, much later on in life. So again, just to summarize, that Life Simple 7 gives you 7 years longer of healthy living without cardiovascular disease. And interestingly, when we looked at all-cause morbidity, so this includes things like arthritis, dementia, COPD, all those sort of chronic diseases of aging, you can see that the same sort of principles held true. It wasn't just about cardiovascular disease. By the way, cancer's in here also. But you see greater compression of morbidity as well for all-cause morbidity if you have better cardiovascular health in middle age. Okay, so I know what you're saying. You're saying, okay, so these people are living longer. Aren't we just going to spend more money on them during their Medicare lifespan? And the answer is, in fact, no. What you see here, especially on the right, the cumulative Medicare costs, so the entire Medicare lifespan, as people live through it, you can see that for people with all favorable cardiovascular risk factors or good cardiovascular health, we spend about $75,000 less on them cumulatively during their Medicare lifespan than people who had 2 or more major risk factors back in their 40s. So again, this could be a really important way for us to solve the Medicare budget problem, is if we focused further upstream and got people into better cardiovascular health much earlier in life. Okay, so just kind of a quick pause here. So far, the implications of that ideal cardiovascular health factor pattern that I've shown you, clearly people with prevalent risk factors in middle age need intensive prevention, right? We can't put the horse all the way back in the barn, but we can certainly reduce their risk with effective therapies and with effective lifestyle changes. So that's an important thing that we need to continue doing, particularly as clinicians. But if we really want to prevent cardiovascular disease, if we want to make it a rare disease, then we actually have to prevent risk factors from ever developing in the first place. We have to create high cardiovascular health, and we have to maintain cardiovascular health as deep into the life course as we possibly can. And this is a concept now called primordial prevention, not letting those risk factors develop in the first place. Okay, so the obvious question, how do we do that, right? How do we actually create and maintain ideal cardiovascular health across the life course? Excuse me, it's a little bit dry here in Chicago as the weather gets colder. Okay, so these data are national statistics from NHANES that show us that unfortunately, the normative experience in this country as we age is that we lose cardiovascular health. So what you see here is that about 40%, only about 40% of 12 to 19-year-olds still have 5 of those 7 metrics at ideal levels. And that falls steadily through young adulthood, middle age to older age. And so, in fact, obviously having high cardiovascular health is pretty uncommon once you reach age 60 or older. So we asked the question, okay, it seems that we're all born with higher cardiovascular health. We tend to lose it across the life course so that it becomes rare by middle age. Is that pre-programmed by our genes, right? Is that something that, is just the human condition, it has to happen, or is it modifiable? Are there, genetic patterns, or are there lifestyles that could actually help us maintain cardiovascular health into middle age? So the first part of that question was answerable with our friends at the Framingham Heart Study, where I worked for a few years, and we went back to them and said, okay, you've kind of got the ideal situation. You've got 3 generations of related individuals and some unrelated individuals. So we can look at the heritability of this cardiovascular health trait in middle age. So they, as you see here, have now examined in the decades of the 40s and 50s a large number of individuals who are related. So we can actually look at the heritability of this trait. How often is higher cardiovascular health inherited? And the answer was that only about 10 to 15% of this cardiovascular health trait is heritable as a package, okay? So that suggests that this is statistically significant. There is genetic influence of cardiovascular health for sure, but maybe 85% of that heritability is unexplained by genetic factors. So there are other things modifiable. It suggests that environmental, behavioral, social factors actually are having a broad influence on cardiovascular health status in middle age. So then we flipped it around and we said, okay, do these young adult behaviors and lifestyles actually, are they the things that can actually lead to modifiability in your cardiovascular health status in middle age? So going back to that Cardia study, again, this is 5,000 Black and white young men and women enrolled in the 1980s and followed on a number of different exams where we were able to characterize their health behaviors and also then look at their cardiovascular health outcome in middle age. And we modeled those health behaviors on the things that you'd seen before in Dr. Stamford's study from 2000. This is now applying those same lifestyle definitions essentially to the Cardia cohort. And what we found was that if you followed 0 or 1 healthy lifestyle in young adulthood, you had about a 2% chance of making it to age 50 with ideal cardiovascular health. If you followed all 5 healthy lifestyles, you had about a 50 to 70% chance of maintaining ideal cardiovascular health into middle age. So that suggests that there's a pretty strong gradient here that healthy lifestyles are the things that can actually help you modify and maintain your cardiovascular health status. And that, for me, gives me a lot of hope, right? That if we get people doing the right thing, if we give them the opportunities to do the right thing with their lifestyle, we can actually maintain a lot more cardiovascular health and have a much healthier population living into middle age. So again, just to kind of summarize this part of the talk, ideal cardiovascular health status is obviously a key indicator of healthy longevity on multiple axes, not just cardiovascular disease. It is heritable, but only pretty modestly so. But it is modifiable, and maintenance of high cardiovascular health is better. The best way to do that, it appears, is through maintaining healthy lifestyles through young adulthood. Okay, so how are we going to maximize the prevalence of ideal CV health in middle age? Again, we need to move way upstream, work with our pediatricians, work with our young adult specialists and internists, and OBGYNs, of course, to try to create and maintain cardiovascular health much earlier in life if we want to win the game here. Okay, so switching gears a little bit, what is it about cardiovascular health that actually prevents the events? So we've been able to look a little bit deeper at this, and it's a really, I think, it's an important question, because is it just not having risk factors, or is there something about this package that's more than the sum of its parts of the absence of risk factors? And it's a difficult question to answer, but we've been able to look at it a couple different ways. So one of the first interesting things that we were able to do was actually look at whether cardiovascular health status is related to subclinical cardiovascular disease. And as you would expect, absolutely, and of course it is. Right, so you can see here when we characterize people in MESA based on their cardiovascular health score, and then call them low, moderate, or high based on that health score, you can see that there's a much lower prevalence of coronary artery calcium. Sorry about that. In people, click that through. There we go. Much lower prevalence of coronary artery calcium in people with high cardiovascular health in middle age compared with low cardiovascular health, not surprisingly. And roughly a 70% lower risk of having any coronary calcium in middle age if you have high cardiovascular health versus low. CAC scores are lower in people who have CAC. The carotid IMT is substantially lower as well. And of course, the LV mass index is also significantly lower in those people with high cardiovascular health. All of that kind of makes sense, right? Not surprising, but good to show. So now let's dig a little bit deeper. So these are some data from one of our studies where we characterized cardiovascular health status. This is the same group where we were able to do it at age 41. And then a number of years later, we brought them back for some imaging. And this is actually coronary MR angiography without contrast, just black blood imaging. What you can see here is that we take different sections of the coronary arteries in these individuals. This one happens to be a 72-year-old who had non-ideal cardiovascular health about 40 years prior. And you can see here in his left main coronary artery, first of all, the lumen is small compared to the thickness of the wall. The wall is irregular in its thickness, and there's this low attenuation region, which is actually turning out that that correlates with lipid-rich plaque. And you can see again in the LAD, thick wall compared to the size of the lumen. In the RCA, a little bit of low attenuation stuff, and again, irregularity in the wall. So this is a person who 40 years earlier had non-ideal cardiovascular health, and now when we image his coronaries, he's got kind of coronary remodeling that is adverse in its profile. So compare that now with a 70-year-old man who had an ideal cardiovascular health profile 40 years ago. And here you see his left main, again, the lumen compared to the wall, the ratio is much more favorable. LAD, you see the same thing. In the RCA, he's got a little bit of disease, but overall, certainly much less than we saw in that other gentleman comparatively. So how do we then do this across multiple individuals? Well, kind of to summarize what we see here is that there is atherosclerosis in these people with ideal cardiovascular health decades later. So they are developing atherosclerosis, but it's much more benign appearing. They have less of that low attenuation stuff. The ratio of the lumen to the wall is much more favorable. They have much less remodeling. So the wall is thickening. They do have atherosclerosis, but it looks like it's more sclerosis and less athero in these people who have ideal cardiovascular health decades earlier. And then in the people who had non-ideal cardiovascular health, it's more athero in the sort of traditional sense that we think of with plaque and much more thickening and remodeling of the coronaries. So it kind of generates this hypothesis that if we can maintain cardiovascular health, not only does it prevent the development of some atherosclerotic plaque, but it also promotes the development of a more benign form of atherosclerosis that's less likely to lead to events. And again, maybe more sclerosis rather than athero, which is an interesting thing that we're now trying to pursue with some of our current studies. Okay, so I've moved you back all the way from older adulthood, all the way to young childhood. Can we go even further back? Is there intergenerational transmission of cardiovascular health, and does it matter? So now we're going to focus on this part of the spectrum and think about some of those early life exposures and even fetal exposures that might influence our lifelong cardiovascular health trajectories. So these are some of our more recent data. The first question we asked was, in NHANES, what is the cardiovascular health status of American women who are pregnant now? And what you see here is that it's not optimal. The mean cardiovascular health score out of 14 for pregnant women is 8.3, which is actually a little bit worse than the mean cardiovascular health score for non-pregnant women in this country, ages 20 to 44. And you can see that in general, the things that are driving these less favorable cardiovascular health scores are body mass index, low physical activity, and poor diet. So those are sort of the three major things that are contributing to lower cardiovascular health scores among pregnant women in the US at present. So with that sort of baseline, we asked, well, does it matter? So looking at the potential for intergenerational transfer of cardiovascular health status, we used our hyperglycemia and adverse pregnancy outcome study, which had actually characterized women at 28 weeks gestation. And fortunately, they got a fair amount of really good data on cardiovascular health status in these women, even though the construct hadn't been invented at the time. So we were able to kind of backfill what the cardiovascular health status was of these women at 28 weeks gestation. And then not only did we look at birth outcomes, but we were actually also able to look at the children who were invited back for an exam 10 to 12 years after their birth. So we were able to look at both offspring and mom cardiovascular health status 10 years later after the cardiovascular health status during gestation had been characterized. So long story short, first looking at the pregnancy outcomes, better cardiovascular health shown here in green compared to really poor cardiovascular health shown in red was associated with less preeclampsia, less unplanned C-sections, less low birth weight, less high birth weight, and the babies actually were leaner and had more insulin sensitivity, less insulin resistance than the babies who were babies of moms with poor cardiovascular health during gestation. So interesting. So birth outcomes look a little bit different. But also 10 years later, what we found was that compared to women who had poor cardiovascular health status in pregnancy, the women who had high cardiovascular health status in pregnancy were 8 times more likely to have kids with ideal cardiovascular health status 10 years later. So again, not causal, but certainly a strong indicator that these things are traveling together, that what mom's health looks like during pregnancy is at least a forecast of what the kid's health is going to look like at birth and even 10 to 12 years later in early adolescence. So important that we think about getting our moms healthier as they head into pregnancy so that they can actually launch their children into healthier trajectories of cardiovascular health as well. So how might that work? Well, our current sort of research is really focusing on the epigenome, and many of you are aware that we inherit our fixed DNA code, but we actually also inherit these DNA methylation groups and other modifications of that fixed DNA, which actually determine how well we can express those genes. So it's not just about what the code is, but whether we can actually turn those genes on and off at different points in the life cycle that kind of determines what our health looks like. And it turns out that intrauterine exposures actually influence your DNA methylation and later on in childhood and adulthood, how well you can express those genes. So it really might matter, what kind of imprinting is happening in the intrauterine environment. So I think, again, you're all quite familiar with the epigenome. We've been able to look first in adults, this is going back to that Cardia study, at methylation patterns over time and relate it to those cardiovascular health trajectories. And what we found is that there are certain sites or hotspots in the genome that seem to be associated with the maintenance of higher cardiovascular health across time. And when we actually look at this in mediation analysis, statistically, we can see some of these hotspot sites where methylation is occurring more or less often based on your cardiovascular health status are related to some of these important intermediate subclinical outcomes. So as one example, statistically, we were able to show that 3 sites of DNA methylation actually explained about 20% of the association between cardiovascular health status in young adulthood and midlife coronary artery calcification status. And these were genes that have, sort of reasonable plausibility, both in terms of what happens to their expression with DNA methylation at that site, but also what their role is in the pathway that could lead to potentially atherosclerosis. And similarly, we also were able to show the same kind of relationship for upstream cardiovascular health status, intermediate epigenetic modification with DNA methylation at certain sites, and then downstream left ventricular mass index. And that's what you see here as well in the Cardia study. And again, 3 particular sites explaining, statistically at least, 29% of the variation in LV mass index. And these were related strongly to cardiovascular health status. So kind of tantalizing that, these are potentially modifiable sites where we could intervene and actually interrupt the progression from poor cardiovascular health to poor subclinical markers. Okay, but thinking about this a little bit more holistically, we can actually use epigenetics as a clock because there are certain points in the genome that tend to get methylated at a more predictable rate that are related to factors of aging. So if we look at your chronological age, and then we look at these methylation sites across the genome, we can see some people who appear to be biologically, epigenetically younger than their chronological age. And we see some people who are actually look to be older than their chronological age. So we can kind of create this score called a Grimm age score that's based on their epigenetics. And it's really a biological clock rather than a chronological clock. And what we've shown is that your cardiovascular health status in young adulthood does predict your epigenetic age in middle age. So not surprisingly, these healthy factors and healthy behaviors do influence your DNA methylation and therefore your epigenetic age. But then importantly, we've also shown that your early life cardiovascular health score over 20 years is associated with substantially younger epigenetic ages. So for example, if you have high cardiovascular health from early adulthood to middle age, on average, biologically, you're about 8 months younger than someone who had poor cardiovascular health during those years. So that's interesting. And we were able to actually validate those findings in the Framingham Heart study as well, which is a kind of a fun recent one. Okay, so just to wrap up, where are we headed from here? Well, we have a number of different studies going on. We actually have an AHA-funded children's research network where we are actually looking at that potential for intergenerational transmission. So we will be able to tell you probably in another year about the epigenetic modifications that are happening in utero to these kids. And actually, because we have cord blood from birth, and then look at them 7 to 8 years later to understand what's happening with their cardiovascular health. So stay tuned for that. We also have a really fun, sorry about that. We also have a really fun study that's just getting started looking at really well done social epidemiology, understanding what the social determinants of health might be from birth to age 20, and then looking at young adult cardiovascular health status. So this is linked to a pre-existing social epidemiology study called the Fragile Family Study, which none of us had ever heard of. They've published over 1,000 papers on social epidemiology of children as they grow from ages 0 to 20. Best social epidemiology study I've ever seen. No health outcomes ever measured. And we were fortunate enough to partner with them and are currently doing a young adult cardiovascular health exam as well as some carotid imaging in these young individuals to understand what those social determinants are in terms of indicating what young adult cardiovascular health looks like. So now to the action items. What can we do as physicians and as individuals living in families and communities to try to improve cardiovascular health? Well, I would refer you to the website for actually scoring cardiovascular health. And we use this with our patients. It's really useful. If you Google either My Life Check or Life Simple 7, they can actually put in their email and then they can basically otherwise anonymously check their cardiovascular health score and then look how it changes over time. And that can be a good motivator for them to see how their cardiovascular health is improving. No question, as we've said, we have to continue our maximal efforts in secondary and primary prevention for those people who already have risk factors. But in those who don't, we've got really strong evidence that primordial prevention can work, right? The DPP, the Diabetes Prevention Program, the DASH sodium diet, smoking cessation, weight maintenance, healthy pregnancies, all these things lead to better health outcomes in the near term and better cardiovascular health and those outcomes in the long term. But I also would challenge you to kind of step outside of your clinician hat and think of yourselves as advocates. I think in the past, physicians were very, very powerful advocates. And we've kind of lost that voice, and it's time to bring it back because I think we desperately care about population health. We certainly understand the influences that social determinants have on our patients' ability to have or maintain high cardiovascular health. And so getting involved, and the AHA is a great way to get involved through you'rethecure.org, talking to your representatives, talking even to your local community representatives, and creating a healthier environment so that default choices are healthy choices, not default choices are fast food, high caloric, high sodium, high sugar. You know, we need to have better alternatives for kids in our schools, for young adults, obviously living in our communities as well. We need to get obviously away from vaping, which is going to hook a whole new generation of individuals on nicotine and undo some of the amazing work that's been done for the tobacco endgame. All sorts of things here that you can get involved and have an important voice in. If you go through you'rethecure.org, it's a great start. And then contacting your local AHA staff, they have very active advocacy groups, and they can give you the talking points, teach you how to interact with your representatives, and turn you loose, and you can do an amazing amount of good and with a very high impact in a short amount of time. So what happens if we're able to do this? Well, these are some data from one of our former fellows, Josh Bundy, and he used simulation modeling to say that, okay, if we could, again, magically snap our fingers and turn a certain proportion of the American population into people with high cardiovascular health, what would be the difference? And what he showed was that, for example, if we could just get 50% of adults into high cardiovascular health, we would prevent almost 1 million cardiovascular events each year in this country. So this is really powerful stuff. And by the way, it can happen incredibly quickly when you start to actually make changes in diet that are meaningful, changes in smoking prevalence, changes in blood pressure control. These things can happen very, very rapidly. And so, it can have a broad impact in the population. Okay, so just to finish, what I hope I've projected to you is, thinking about flipping that risk paradigm on its head has actually led to some, I think, important insights that, by studying healthy people, we can actually understand how to maintain health across the life course. Maybe it is more than the sum of the parts if you maintain all 7 of these factors at ideal levels into middle age. Okay. Lifestyle factors seem to be more powerful than genetics in modifying or maintaining your cardiovascular health, and primordial prevention strategies are clearly going to be key for that. And that there's some interesting mechanistic aspects here that, maybe epigenetics are an important way that signal is transmitted from mom to baby, and then as we age within our own bodies, of course, and that maybe those people with high cardiovascular health do develop atherosclerosis, but it's much, much more benign. So we have lots of tools in our research toolbox, lots of tools in our, I think, clinical and advocacy toolbox to help our patients think about cardiovascular health in a new way. And with that, I am happy to take your questions. I'm so grateful for the opportunity to be with you today, and thank you so much for your attention.
Thank you so much, Dr. Lloyd-Jones. That was just absolutely amazing. Guys, don't be surprised if I, replay this talk at several other grand rounds, because that's how wonderful I think this has been. So I won't take up too much time. Let's go directly to questions. Dr. Zaret, I'll take one from you, then Dr. Spatz afterwards.
Well, thank you for a wonderful talk. Your data are all based on the composite of 7 factors. And I was wondering about studies that look at the relative contribution of each over time. Certainly at age 75 or 85, you may have a very different effect on a particular risk factor than you do at 15. And particularly now as the population is aging, this may become even more important.
Yeah, I think it's a great point. And I want to be clear that, we know that there are sort of differential effects of some of these risk factors, especially in terms of short-term risk on cardiovascular outcomes, right? And so I think that's where, the difference between population studies, observation, and clinical judgment are really important. So at a population level, each of these things over the long term is mattering fairly similarly, each of those 7 metrics. But as a clinician, if I had someone sitting in front of me and there were 3 or 4 of these metrics that we had to work on, I would absolutely choose smoking, first, foremost, and most important. I would absolutely want to control their blood pressure first, because those things are not only risk factors, they're also triggers, right, for those cardiovascular events that might be going to happen sooner. So I would think about the context of, where we are in the life course, what's most important to reduce risk immediately in the short term, and then work on some of those other things in the longer term, hopefully using some of my friends like, dietitians, nutritionists, to improve the diet in the long term, to, expand their capacity for physical activity. So I think, that's where clinical judgment's really important in applying this sort of to the individual patient sitting in front of us. Does that make sense?
Yes, thank you. And are you looking in any more depth at the population in their 80s now?
We are. We have a couple of sort of super aging studies here at Northwestern that we are now engaging with to understand, if we can, where they came from, but also what's mattering today in terms of keeping them healthy agers. And Dr. Stamler, not least among them, because he is 102 and still sharp as a tack. Orthopedically a little bit challenged, but sharp as a tack, and still editing our papers quite vigorously as we pass them under his pen. So it's a great idea, and absolutely agree we should be looking at that.
Thank you very much.
Thank you.
Erica?
Sure. Hi, I get to go after Dr. Zaret, who is our Uber model of health, avid runner, and well into retirement, although I don't know your age, and I will leave it there. This was a fantastic talk, and thank you so much for your work, which has been a guiding force in my own career, especially balancing population health with individual health and individualized risk assessment. And congrats on a great AHA meeting. I don't know how you pulled it off because I can only imagine the challenges of a virtual meeting. My question gets to this idea of primordial health and primary prevention, especially in adolescents and young adults. Your study with Nori Allen using latent class analysis and showing the trajectories of health starting in adolescence was just such a milestone moment in my own thoughts about where we need to be directing efforts. And then the most recent study, which sort of has a bee in my bonnet, came out in NEJM over the summer, which was by the Today investigators looking at adolescents who had type 2 diabetes. They had enrolled them in a randomized controlled trial of medication and lifestyle. And then they followed them up 10 years later, and they were only about 25 years old. And about 50 to 70% of them had hypertension, hyperlipidemia, retinopathy, CKD. So, we're just clearly failing our population. And you spoke about the social determinants of health and ways that we can be advocates. And, it still feels like we haven't made a lot of progress. So I was wondering, are there models out there? Are there positive deviant communities that do this well and that we can use as a blueprint for what we need to do to really move the mark on lifestyle factors, addressing women in pregnancy or pre-pregnancy planning that really builds a culture of health as we try to, prevent the onset of disease, especially in these younger age groups? Thanks.
Such a wonderful question. We could spend all day on it. I'll try to be very brief. Yes, actually, so the first populations that we found that really seem to have won the game are actually indigenous peoples who are very agrarian in their approach, very active in their lifestyle, and seem to, again, avoid the consequences of cardiovascular badness by pursuing those relatively healthy lifestyles, those much more plant-based diets, and avoiding processed foods and things like that. Now, there are also emerging examples, and I will point to where they've created a policy environment that is much more favorable to making healthy choices the default choice. So, thinking about the North Karelia experience in northern Finland, a very important population-based approach to crafting a healthy environment. Even in Franklin County, Maine, kind of replicating that same experiment here in the US, where they created a much healthier population by manipulating, really the policy environment. And we've got some sort of islands of hope in looking at what's happened with sugar sweetened beverage taxes in Philadelphia, in Berkeley, where you see immediately 30 to 40% reductions in the amount of calories consumed from sugar sweetened beverages in young adults. And, I think those kind of things, those natural experiments we can do with policy can point the way to setting the stage, tilting the table a little bit more favorably so that clinicians are working in an environment where we can actually make a bigger difference. Yeah.
I think we have time for maybe just one question. Dr. Benda, I saw your hand up, so I'll let you take it. We're at the top of the hour.
Okay, Don, thank you so much for that great talk and all your great work.
Thank you.
I wish you were here in person. I'll be brief here. I'm interested and fascinated by the link between cardiovascular health and other non-cardiovascular health outcomes, as you said, like incident cancer. And I think we're appreciating more and more of these links, for example, in the context of clonal hematopoiesis, where there are risks for both. You said change does matter. So I just wondered whether there were any types of change. What I'm thinking of is that some cardiovascular risks may be markers of underlying health genetics or epigenetics that may really lead to multiple diseases. I mean, obviously, smoking cessation, weight loss with better metabolic parameters, that's going to help. What about difficult hypertension and hyperlipidemia that require aggressive pharmacologic therapy? Is that a different kind of change, maybe matters less, and you actually, that's an indicator of something that may lead to other diseases as well?
Yeah, it's a wonderful question. And I have a colleague here, Qiang Liu, who's been in the game a good long time. And he talks about this point of no return concept. And, we think about it with type 2 diabetes sometimes, right? That once you have stressed out your beta cells long enough, they just can't keep up, right? They can't produce enough insulin, and also the tissue things that are happening that make us more resistant to insulin. You just never really fully get back to a lowest risk state or a optimal metabolic state. And I think that that's true. I think once there's enough vascular damage from overexposing ourselves to sodium, overexposing ourselves even to high normal blood pressure, it becomes a little bit inevitable that we're going to see continued increases in blood pressure over time. We can't put that horse all the way back in the barn. And so I think that's why it's so important to think about moving upstream. Change will always help some, but the earlier we do that change, the more impactful it's going to be in kind of limiting that irreversible damage that can occur over the lifespan.
Thank you.
Thank you again so much, Dr. Lloyd-Jones. Again, this is absolutely wonderful having you. Thank you for spending the morning with us here. And again, we look forward to having you here sometime in the near future. Thank you again, everyone, and see you again next